Okay. All right. So, um, we are excellent RN. Okay. First of all, I just want to do some little introduction. Okay. So, we are excellent RN. What we just do, or what we basically do, our mission is to prepare nurses to take the NCLEX exam. Okay. Yeah, myself. Okay, let me just open my camera and see. I think most of us know me. Okay, I've seen you before. Most of you here knows Archimedes. Okay, on the various platforms, you know Archimedes or Bosaki. Right. Yes. So this is me. Okay, if you can see my face. All right. Good. Um, I have been doing this, okay, together with my team for almost 3 years now. We've been helping nurses to pass the NCLEX exam. Okay. Okay. We've been helping we've been helping a lot of nurses to pass the NCLEX exam for almost 3 years now, right? Yes. If you mention Bosaki or Archimedes anywhere, they will tell you, about us. Okay. So we just thought it wise to organize this free NCLEX class. Okay. Not only for NCLEX test tickets, for everyone outside or everyone who wants to just learn something small or learn about compartment syndrome so that whilst practicing, when a patient is rushed to your unit, okay, you are the ER, a patient is rushed to your unit with fracture, then, certain things are going on. How do you see this is compartment syndrome? And how do you manage? A patient comes with fracture and is being booked and then scheduled for cast. Cast was applied 3 days ago. You see some changes. How do you know that there's something wrong going on? Okay, so that is just something we just want to learn today, and then we can make progress. Okay, please, are we all on the same page? Because we are starting the class. Are we on the same page? Are we on the same page?
Yes, we are.
Yes, sir.
Okay. All right. Good. All right. Good. So let me share my slide and then let's start. Okay. Let me share my slide and then let's start. Good. Please, can you see my screen? Can you see the compartments? Can you see my screen, please?
Yes, please. We can see the screen.
Okay. All right. Good. So when we say compartment syndrome, okay, let me first of all ask, please, what comes into mind when you see
Archimedes, you
compartment?
can make me a co-host, eh?
All right, Esther, Mimi, okay, you are welcome. You're welcome. Okay. You were not here, so I was not able to introduce you. By the way, I do this thing with with Sister Mimi and then Amingo. Okay, currently. So Amingo is quite tight. Okay, but Sister Mimi is here. Okay. Sister Mimi is here. All right. So let me just ask when you hear compartment syndrome, please, what comes into mind? Compartment syndrome, what comes into mind, please? Compartment syndrome. What comes into mind? Yes. Anyone to try? Please, if you want to speak, just raise your hand, okay? Or you can send something to the chat box and then I can read. Okay, I can just read. Okay, all right. Anyone to try? Compartment syndrome. Anyone to try? Anyone to try? Hey, you're all quiet. But please, can you hear my voice? Maybe you can't hear my voice. That is
You
why
are
you're
audible,
quiet.
sir. You are very audible.
Okay. All right. So
Can I try?
he said, okay, Madam Mata, please try.
I
Yes,
think
please
we
try.
should try. I think when there is when there is pressure in the muscles, especially when there's surgery, and then it's
Okay.
impeding the flow of blood in circulation through that site of the surgery.
Okay. Okay. All right. Good. You've done very, very, very well.
And
Okay.
also there's inflammation. There can be inflammation as well, which is obstructing the blood flow as well.
Okay. All right. Okay.
Hello,
All right.
sir.
Yes, Madam Linda. Yes.
I also remember something small that sometimes post-fracture, there's pressure
Okay.
in the muscles where the
Okay.
fracture occurred. So it impedes on blood flow, which causes pain, persistent pain, and paresthesia and some kind of cold to
Okay.
clammy skin as well.
Okay. All right. So I think I'll take these two responses for now. I think it's a good what do you call it um kindly hold on. Okay. So I think it's a good submission so far. Okay, we've all made a good submission so far. All right, good. So when we say compartment syndrome, okay, when we say compartment syndrome, okay, someone wrote something in the chat box. Let me read. Okay, let me just read. Okay, let me just read. Said the increased pressure reduces blood flow, which can cause tissue ischemia, impermanent muscle, and damage. Okay, that is fine. That is fine. Okay. All right. So we are starting. Okay, let's bring our attention here so that we can get everything we should know. So that whilst we are practicing, we shall practice safe. All right. So when we say compartment syndrome, in a normal human being, when you pick the musculoskeletal system, okay, when you pick the musculoskeletal system, we have the upper limbs, we have the lower limbs. Okay. Yes, the upper limbs and the lower limbs. Then the upper limbs and the lower limbs, or let me say the entire body is made up of muscles. Okay, made up of muscles. When you say compartment, okay, when we say compartment simply means that a human body muscles, nerves, and then blood supply. Okay, so when you pick your upper and the lower extremity, and then you just go into theater, okay, and then let them just cut the upper surface of your, let's say your hand. I'm just using your hand or your leg or tibia. Let me just use your tibia region or your lower limb. Let them just cut it for you to see the inside of your limb. You will see compartments, okay, because it is the compartment that is made up of your muscles. When you say compartment in the human body, it's simply your muscles, which contains nerves and then blood supply, helping you to perfuse your muscles so that you can move your body. So this compartment is all about your muscles, okay? It's all about your muscles. It helps you with structural nature. It helps you with your body functions, how you move your body, how the body itself is even structured, okay? So in anatomy wise, you will say that your muscles is made up of the compartment which contains blood supply and the nerves. Okay, very good. So if you see this slide, okay, if you check this slide, you could see that there's the various compartments. So this is just someone, and let's say they've bisected the patient's body, and now they want us to see inside of the body. Okay, they want us to see inside the body. So you see the compartment. Okay, have you seen the compartment? What they've just drawn like shapes. Okay, these are the compartments, and then this compartment is made up of what? Muscles, nerves, and blood supply. Okay, your muscles, your nerves, and your blood supply. So your upper limbs, your lower limbs are all made up of what? Compartments. It helps you to move. It helps you to maintain your structure or anatomical positions. It helps you to maintain the structural nature. Okay. So this is all about what? Compartment. When you say compartment, that is what you mean. It means that when you bisect a human being, what you see next after you bisect, you take off the skin is the compartment, your muscles, your nerves, and your blood vessels. That is all. Now, this compartment, we have the anterior, we have the posterior, we have the medial. I will not really bore you a lot with this. A lot of anatomy, okay? Good. So we have the anterior, the posterior, and then the medial. Now, surrounded by this compartment, that is the muscles, your nerves, and your blood vessels. When I say compartment, just know your muscles, blood vessels, and nerves. This makes up your compartment. That is if you bisect a patient, if a knife bisects you deeply, you will see compartments, and the compartment is made up of your muscles, your nerves, and blood vessels. That's all. Okay. This makes up your compartment. That is what we mean by compartment. Good. Now, this compartment, they are being surrounded by a tissue. It is a connective tissue. We call it the fascia. Okay. We call it the fascia. Okay. Fascia. We call it the fascia. This compartment is surrounded by this fascia. Okay. Very good. Now, one thing you should know is that this fascia is inelastic, meaning that it does not expand. Okay. This fascia does not expand. It is inelastic. it is inelastic. It doesn't expand. So when there is pressure in this compartment, the surrounding or the thing that surrounding the fascia does not expand to accommodate the pressure. So the pressure keeps on building up in the compartment. Eventually, there will be reduced blood flow because the pressure keeps on increasing, suppressing nerves, and then preventing enough blood flow to your muscles or to your compartment. So the whole point is that the fascia around your compartment does not expand. They are inelastic. So if something happens to your human body or something happens to your muscles and there's increase in pressure in the compartment, there is no way it will expand because that is how the fascia is made up. It's made up of. They are made up of inelastic connective tissues. Okay, so they don't expand to accommodate the pressure. So if pressure begins to build up in the compartment, it stays in the compartment and begins to suppress nerve function and then what? Reduce blood flow. Please, is it clear? Are you following? Please.
Yes, sir.
All right. So that's all about what? The compartment syndrome. So the definition, compartment syndrome is a condition that occurs when pressure within a muscle compartment increases to the point where it compromises blood flow and function of the muscles and nerves within the compartment. So that is all about compartment syndrome. When you say there's compartment syndrome, I have explained what the compartment means. When I say compartment, it means that your muscles, which contain nerves and blood vessels, that's all. Okay. Now, there can be increased pressure in this compartment. Probably you had a fracture. So you are the emergency unit. A patient was rushed to your unit from an RTA. Okay. Then you realize that the patient's limb was what? Was swelling up. It could mean that because anytime there's a fracture, there's a wound. Don't forget, the body will respond to the fracture through inflammation. And we all know the 5 signs of inflammation. We have pain, we have warmth, we have swelling, loss of function, redness. Okay, these are the 5 signs of inflammation. So swelling is part of the inflammation. So if you have a fracture and the human body begins to react to the fracture, what is going to happen is that there's going to be swelling in the compartment. Now, when the swelling begins in the compartment, the fascia will not expand for you to accommodate the pressure. So the swelling begins to build up and increase pressure in the compartment. When the pressure begins to increase in the compartment, eventually, patient will not get enough blood flow through the muscles, and then there will be what? Nerve damage. This is when we term the patient to be having what? Compartment syndrome. Please, is it clear? Is it clear, please?
Yes, it's clear.
Okay. So that is all about compartment syndrome. Okay. When you say compartment syndrome, it simply means that there's a pressure in the compartment, and then this pressure at a point it has grown to that point that it doesn't even allow blood flow to move through your muscles and the nerves, impeding muscle function and then nerve function as well. Okay. All right. So this is just a pictorial view of the fascia. Okay. As you can see, it is all over our human body. Okay, it is all over our human body because all over our human body we have muscles. Okay, so your muscles together with blood supply that perfuses them, and then the nerve function to help you move your muscles, to help you move your body, and then surrounded by the connective tissue, which is the fascia, makes the human body. Okay, all right. So that is what you can see. The examples of the fascia. You see around your head, your thigh, your legs, everywhere. You see the fascia because you have muscles all over. Then the next picture you see beside it is a clear picture of a patient who is having compartment syndrome. You realize that one limb is very, very big and the other is small, or the other is normal. So you see the diseased limb could simply mean that the patient is suffering from what? Suffering from compartment syndrome. You see there's increased swelling. There are no hairs. Why is that there's no hair? There is no hair because we need enough oxygen flow through your muscles to even help with hair production. So in compartment syndrome, the patient pressure in the muscle has increased to the point that it doesn't even allow blood to flow. How can we get hair production? Okay, so the patient is having a big limb as compared to the other because there's increase in pressure. And this can be caused by a lot of factors, which we are going to very soon. Okay, so let's go to the causes and risk factors of compartment syndrome. let's first look at the external
Just
factors.
like a minute.
Yes, Mimi.
Yeah, I want to chip in one thing here.
Okay.
You know, anytime we talk about compartment syndrome, I always tell our students that, you know, blood contains life. You get wherever blood is, we always say there's a life in the human. You get it? So let's take it this way. There's impeded blood supply to that area. So which means there's loss of life to that side of the body. You get it? So which means that whatever activity that goes on in that part of the body becomes what? Impeded. So like Bosaki rightly spoke about, hair needs what? Life. It needs what? Nutrients to grow. So which means there will be hair loss. Aside hair loss, other characteristics Bosaki will be mentioned, like the place becomes shiny, scaly, and the rest. All because of the impeded blood supply to that area, the loss of life to that area. So which means all other function that goes on there becomes dead. Please, do we get it?
Yes. Thank you so much. Thank you.
Thank you too.
All right. Good. So now let's focus on the what do you call it? The risk factors. Okay. Okay. Is there something in the chat box? Let me see. There's a hair loss. Okay. Once there's compartment syndrome, you can list. Yes. Yes. Eventually, you see, when eventually the blood supply is impeded for long, when it's impeded for long, there will be no, because the body needs, or before we can have proper hair production, we need oxygen and nutrients. Okay. So once the compartment starts, there's increase in pressure in the area, and then you don't respond to the situation as soon as possible, it will impede blood flow. Once blood flow is impeded, what you are going to expect? Poor blood supply, poor oxygen, poor nutrients. Therefore, the hair loss will come inside. Okay. All right. Good. All right. So the external factors, we have cast. What is POP? I'm sure most of us have seen POP, okay, before, which we will talk about POPs very soon, okay, or cast very soon. So POP, sometimes when a patient is admitted to your ward or into your unit by way of fracture, we apply POP. The basic function or some basic function of POP is to what? Immobilize the limb so that, we can have a well-structured and proper healing of the patient limb. Now, sometimes when they apply the POP, it becomes too tight. Now, when the POP becomes too tight, they compress on your muscles. So they reduce the compartment size. Once they compress on your muscle and decrease the compartment size, eventually there will be increase in pressure because the size has been reduced. Once there is increase in pressure, you might get compartment syndrome because the fascia will not expand to accommodate the pressure. So POP, when it becomes too tight, will press or compress tissues and nerves and the muscles, reducing compartment size and can lead to a compartment syndrome. Two, we have bends. Bends, we all know that when your patient have bends, there's what we call third spacing. Okay. Third spacing. What is third spacing? Third spacing means that there's increase in permeability. So there's what? Shift of fluid, causing what? Edema. So when you have bends and there's shift of fluid by way of third spacing and it's causing edema, when you don't respond to the situation as soon as possible, okay, it can also increase pressure because we know edema. Edema is when there's accumulation of fluid. It can increase pressure because edema will lead to swelling. Once the swelling keeps on increasing and you don't manage the situation on time, it can lead to compartment syndrome. Then bandaging, okay. On the bends, we have ISCA. When a patient have bends, it becomes like a mark on the patient, like an ISCA. It becomes very, very hardened. Okay. And ISCA is like a hardened layer once the bend has been healed. All these things can increase pressure on the muscles, okay, and can cause compartment syndrome. Then we have bandaging. Of course, patient comes to your ward with wound. You dress the patient wound. You make the bandaging too tight. When the bandaging becomes too tight, it will increase pressure or it will compress on what? On underlying tissues and compartments. Eventually, it will increase pressure and can lead to compartment syndrome. Then you have tight clothing, okay? Though it is rare, because tight clothing those days, people used to wear pencils, okay? Yeah, pencils, trousers and the rest, okay? Which is very, very tight, but then, it's not really common, but it can happen. If you eventually keep on finding yourself wearing tight clothing, it can lead to what? It can lead to what? Compartment syndrome. So these are the external factors, some of them that can cause compartment syndrome. So please, let's take note on our unit. Please, when you are doing dressing, that is why anytime you are doing wound dressing, you assess or you do the dressing with the patient. Once you get to bandaging, ask the patient, please, is it too tight? Keep on, asking. If the patient says it's too tight, please don't go ahead. Take off the bandage and start again. Try as much as possible that you don't cause complications like compartment syndrome. Because if the dressing is too tight, it might cause what? Compartment syndrome. Then we have the internal factors like fractures. Okay, fracture. When a patient gets fracture, or you are at the ER, a patient was rushed to a unit fracture. I explained. Anytime you get fracture, there's inflammation is going to set in. Patient body will respond to the fracture because there's a bone, there's a breaking continuity of the bone. Okay, there are a lot of inflammatory that will be released just to respond to this fracture. This will cause swelling because one sign of inflammation is that the body will swell up. Okay, once they swell, they begin to do what? They begin to cause what? Pressure in the compartment. Another aspect of the fracture is bleeding. When a patient gets a fracture, let's say closed fracture, closed fracture, meaning that there's no opening, but you can see a fracture inside. What happens is that they can be bleeding into the tissues, into the muscles. When the bleeding keeps on increasing without any management, the patient keeps on bleeding and bleeding and bleeding into the surrounding fracture. It will accumulate because blood is like water. They can accumulate. Okay, and the one thing about blood is that they are even thicker. So once they keeps on accumulating, they can begin to compress. Okay, because the pressure will increase. They will compress on where? On the compartment, which is your muscles, your blood vessels, and your nerves, and they can cause what? Compartment syndrome. Then we have soft tissue injury by way of, let's say, a blow. Someone hit you like a blow, or there's some hit to your skin, to your body, and there are some damage to underlying tissues. All these things can increase pressure by way of inflammation and can cause compartment. So we have DVT, deep vein thrombosis. I'm sure you all know the most commonest vein that suffers from DVT is what? The saphenous vein. Okay, the most commonest vein that suffers from DVT, the saphenous vein, right in our lower limbs. When we say the patient have DVT, it means that there's what? A clot in the vein, meaning that there's no proper movement of blood. And anytime blood does not move, you just imagine this. You connected your pipe hole to your pipe, and then you place it inside a barrel to fetch water. By way or some one way or the other, you stepped on the pipe hole. What is going to happen? The water will not flow properly because it is meeting a resistance. So what is going to happen? They are going to pull up and increase pressure. So in DVT, when there's a clot in the blood vessel or in the vein, the blood will not flow, so they will come and meet a resistance and they will pull up. Once they pull up, they begin to exert pressure on surrounding tissues and compartment, which can lead to what? Compartment syndrome. Then we have vascular injury. Vascular injury when your blood vessels stay up the same way. When your blood vessels stay up, causing leakage of blood, pulling up and then causing pressure can cause compartment. And last, we have extravasation from IV infusion. Not only extravasation, infiltration as well. Usually we term it as tissue on our wards. Most of the time you call it the fluid. You are giving a normal sign to a patient. Once you give a normal sign to a patient, you realize that at the IV line site, there's some swelling of fluid. You just, the thing has tissue. Please, henceforth, let's not use tissue. Let's use infiltration or extravasation. Now, the issue or the condition or the situation is termed as extravasation only when the infusion you are giving is a vesicant. But if the infusion is not a vesicant, it is termed as infiltration. So vesicant like potassium is a vesicant. And when you say a substance is a vesicant, it means that it can cause a severe harsh and ischemia to the surrounding tissue faster, okay, at a faster rate. So if you are giving potassium and you see that there's a swelling around the IV side, please stop the potassium, because the moment you make a mistake and continue, eventually you realize that there's tissue death around the IV side, okay? So if the infusion we are giving or the drug we are giving is a vesicant, we call it extravasation. But if the drug or the infusion is not the vesicant, we call it infiltration. Like normal saline ring lactate. If you see that the swelling, it is infiltration. Okay, so these are some risk factors. Imagine you have infiltration, you are giving normal saline, and then the fluid just leaked out to the patient tissues, and then they keep on swelling. You didn't stop the infusion. The thing keeps on swelling. What is going to happen? What do you think is going to happen? There will be increase in pressure because there's fluid accumulation. This will compress on the compartment, increase pressure, and eventually you realize that there's improper blood flow to the compartment and nerve damage, and you see that there's what? There's compartment syndrome. All right, good. So, what are the basic signs and symptoms of compartment syndrome? Okay, so you are at the ER or you are on your ward, the surgical unit, the surgical floor. A patient was sent to the POP unit for POP or POP cast. Okay, then the patient comes to your ward. Then you see signs like pain. It doesn't respond to pain. It doesn't respond to analgesics. You giving your morphine, you're giving your hydromorphone, your NSAID. So the thing does not respond to pain, does not respond to analgesics. You should start thinking of what compartment syndrome. Okay, so we have the 7 P's of compartment syndrome. Okay, we have the 7 P's of compartment syndrome. 1, we have pain that does not respond to analgesics, and that is the earliest sign of compartment syndrome. Pain, the patient begins to feel pain that does not respond to analgesics. Do you know why? You will give all your morphines, all your fentanyls, and the rest, your opiates that you know, and the patient will still feel pain. Do you know when you give the analgesics, at the initial phases, patient will feel comfortable, but the pain will still come up again. Do you know? Because what the patient is feeling is a tissue death. Something is going on in the compartment. There is limited blood flow, and then there is ischemic pain. And that ischemic pain is very, very difficult. In fact, ischemic pain stands tall over just percepting or having a perception of pain. Okay, when the patient is having a ischemic pain, it's really, really difficult. Okay, and it's really, really painful. So you will give your morphine. Patient will feel comfortable, but just with the slightest movement, if the patient just move the extremity, very, very, just the slight movement, because there's ischemia, decreased blood flow and oxygen, causing the ischemic pain, tissue death, it will aggravate the pain. So you will give the morphine, patient move their limbs, and the pain comes again. Give the morphine, patient move their limbs, and the pain comes because there is an ischemic pain. Until we deal with the ischemia going on, the patient will still have the pain recycling. That is why their pain does not respond to analgesics. Okay, that is why their pain does not respond to analgesics. Okay, very good. Then 2, we have paresthesia. That is an early sign as well, but the earliest is the pain that does not respond to analgesics. Okay, paresthesia. Why? The other way we can say paresthesia on our NCLEX or in our nursing, our nursing is what? Is to say either pins and needles or numbness and tingling. Okay, so when you see numbness and tingling or pins and needles, it's the same as paresthesia. Why do patients feel paresthesia? How do they get paresthesia? They get paresthesia because when there's reduced blood flow through the blood vessels, okay, because at a point in time, if the pressure keeps on increasing too much, there's impeded blood flow through the muscles, through the blood vessels, okay, and through the nerves. So eventually, patients begin to have some tingling sensation because there is poor blood flow, and the pressure is even causing nerve damage. Because as I told you, your compartment is made up of what? Muscles, blood vessels, and nerves. So if pressure builds up on your compartment, eventually your nerve functioning becomes what? Becomes to go down or begin to decrease because there's increased pressure, not allowing the nerve to function properly. So they begin to have this tingling sensation called the paresthesia. Then point 3, the next P, we have what we call the pyochlothemia. This in the initial phases of compartment syndrome, when it has not gotten to the latter part. Okay, when it has not gotten to the latter part, patient begin to feel some warmth initially, okay, but eventually when the conditions start going deeper and there's poor blood flow, we all know that blood makes our body warm. So if there's poor blood flow, you will check the extremity, expressing the compartment syndrome, and it has become cold. So what we mean by pyochlothemia is that there is irregularities of temperature the body or the limb does not regulate temperature very, very well. Okay, so eventually or initially there can be warmth, then eventually there's coldness. And even when you check the temperature on the limb that is experiencing the compartment syndrome and you compare to the other limb which is healthy, you realize that there's changes in what? Temperature. And this is what we term as what? Pyokilothermia. Then we have what? We have pressure. Okay, we have pressure. Pressure is caused by the external factor or the internal factor. Is it because of a cast? Is it because of a POP cast? Or is it because of tight clothing? Is it because of DVT? Is there any injury? Okay, is there any injury? All these things increases pressure. Okay, all this is increased pressure. Once the pressure increases, it stops blood flow through your compartment, and it's a sign of what? Compartment syndrome. Okay. Then next point. Sorry, we have pallor. We have pallor. I mean, you all know when a patient limb is well perfused, we all know the color. It is red, right? If your limbs are well perfused, your upper and your limbs are well perfused, and we check it, it is red. It is just red. But in this condition, whereby because of the pressure, there's poor blood flow to the extremities. What is going to happen is that the reddish color we see around the extremities is going to what? Is going to be reduced, which we term as pallor, meaning patients start getting pale because there's impeded blood flow to your extremity by way of the increased pressure. Okay, by way of the increased pressure. Then we have next point, pulselessness. These are lead signs, pulselessness. Because when the pressure in your compartment exceeds arterial pressure, there will be improper flow of blood, which cannot not give you a proper pulse when you try to feel it. Okay, you will check the patient pulse with your hand, and it will be difficult to feel it because the pressure in the compartment has exceeded what? Arterial pressure. Okay, so your arterial pressure is very, very low now, so we can't feel the patient what? Pulse. That is why they get pulselessness. And then lastly, paralysis. If eventually you don't manage the condition as soon as possible, and then it gets to the lateral stage, okay, so paralysis is the late sign of compartment syndrome. Let's take note. Paralysis is the late sign of compartment syndrome. When you don't manage the condition as soon as possible, and then the blood flow is impeded, and you decide not to bother, okay, patient will lose the limb, and then they become paralyzed. This is why compartment syndrome, knowing how to manage and even detecting compartment syndrome on your ward is very, very important. If a patient was rushed to your unit, and let's say at 8 p.m., you are the ward, or let's say 10 a.m., a patient was rushed to your ER, an emergency unit, with fracture. Patient was there, everything was fine. You check the extremity, it is warm. You check the temperature, everything is fine. Pulse, it can be felt. The skin is reddish in color. Then after 1 hour, you give morphine. Patient tells you, Antinous, I still feel pain. You check the extremity, it is getting cold. Please start thinking of compartment syndrome, and it needs immediate intervention. Don't wait. If you wait, the patient will lose the limb out of what? Impeded blood flow, and there can be ischemia and death of tissues. So please what? Please take note of this, okay? Please take note of this, okay? Please take note of this. That is all about what? Compartment, the signs and symptoms. Please, do we have any question on this slide? Any question on this slide? Okay, so I think we are getting the understanding, so there's no question, right? All right, let's move on to the diagnosis. How do you diagnose compartment syndrome? Okay, how can you diagnose compartment syndrome? One, through physical examination. So a thorough what? Okay, a thorough what? Physical examination to assess pain, swelling, weakness, and sensory changes. Okay, a thorough physical examination to assess pain, swelling, weakness, and sensory what? Changes. So as I told you, or as I was giving the example, please, when the patient comes to your ward, a patient has had a cast applied or a fracture, don't stay idle. Consistently, please assess for pain, assess swelling, assess any muscle weakness, because these are the things that will prompt you of what? Compartment syndrome. So you should do a thorough what? As examination. Okay, you should do a thorough examination of the patient limb to help you what? To help you diagnose the situation. Two, you can do what we call the compartment pressure measurement. Okay, compartment pressure measurement. I don't know if this device, we have them on our wards. Okay, but it is a device, okay, it is a device used to measure the pressure within the compartment, okay, within the muscle compartment. It's a device that is used to measure the pressure within the what? Within the muscle what? The muscle compartment. Okay, we call it the striker. We have several machines or several devices. We have the compass and the rest, but this particular machine you see on my screen is the striker. Okay, the striker. Now, as you can see on my screen, they will insert the needle, okay, into your skin, not too deep, okay, just into your muscles, okay, just into your muscles, okay. Then while they insert it, there's a digital pressure reading on the machine. So once you insert it, it begins to read, okay, it begins to read. You can just watch a video of it, okay, maybe later, okay, on YouTube, how to measure compartment pressure, okay. Because of time, I can't show all the videos, okay. So once they insert the needle, it begins to read on the digital side, okay. Then it begins to read. If it exceeds a certain amount, okay, we term it as a compartment zero. So let's look at the normal values. Let's just go to normal values. One, the resting pressure. If the patient is resting, okay, or let me say the resting pressure, the normal resting pressure should be less than 10 millimeters of mercury. Okay, 10 mmHg, okay, Hg. So resting pressure, the normal resting pressure should be less than 10. It should be less than 10. And then when a patient has exercised a bit, okay, so normal exercise pressure, that one should be between 10 and 30. Okay, that one should be between 10 and 30. So anything above these figures would mean that the patient is having what? Compartment syndrome. Then we have what we call the normal delta pressure. It means that it's a pressure difference between compartment. As I told you, we have the anterior compartment, we have the posterior compartment, we have the medial compartment, all in your muscles. So if you want to check, we can do the delta pressure. Let's check the anterior, let's check the posterior. After we are done, let's subtract. The difference we get, if it is more than 10 millimeters of mercury, then we consider it's compartment syndrome. Always they should be less than 10, okay, when it comes to the delta pressure between the compartments. Then the exercise should be between 10 and 30 meters of mercury. So that is how we can use the compartment pressure measurement to diagnose compartment syndrome. Then 3, we can do imaging studies. So X-ray, CT scans, or MRI scans may be ordered, okay, to rule out what other conditions or to assess the extent of the injury, okay. So CT scans, MRI, or X-rays can all be done to assess and rule out what the extent of what of the injury. So these are some diagnostic tests you can do to diagnose what compartments. In fact, when it comes to compartment syndrome, see, before we even use this machine, trust me, the symptoms the patient will present should even help you first, okay? Because the patient will come with what? All right. The patient will come with pain. I mean, you give morphine and it's still not going because of the ischemic pain. You give your morphine, it's not working. I mean, the patient tells you, I am not feeling my limb very, very well. I feel like pins and needles in our Ghana language. Sorry to say this, but I mean, if you're not a Ghanaian, sorry. You say anansi, right? Patient keeps on telling you that I'm feeling this and this and this and this and that. All these are signs of compartment syndrome, okay? Someone says to take the delta pressure again. I said that the delta pressure is the pressure difference between the compartments. As I told you, in the human body, our compartment, that is your muscles, blood vessels, and then what? Nerve surrounded to help you move your body, okay? Within the compartment, we have kinds, so let me say, several forms of compartment. We have the anterior compartment, we have the posterior compartment, and then the medial compartment. See, when we check the pressure between these compartments, it should be less than 10 millimeters of mercury. It should be less than 10. So let's say we check the anterior pressure, and it was, let's say, 8. Okay, or let's say it was let's say 15. Okay, then we check the posterior. Posterior was 5. Now let's subtract the 2. If we subtract 50 minus 5, will give us 10. Okay, so meaning that we are almost, I mean, on the verge. We've not yet gotten to what, or we've not gotten to, I mean, above 10 to say there's compartment syndrome, right? Or we check the pressure. We check the pressure in the medial side. The medial was, let's say, 10, and then that of the posterior was 8. When we subtract 10 minus 8, we get 2, meaning that it's less than 10. It is still not compartment syndrome. If we do, and it is getting like 10 and above, then we can diagnose what? compartment syndrome. Okay, you can assume compartment syndrome for the pressure measurement. All right, good. Okay, all right. Then we are moving on to the management. Okay, we will not waste much time. Okay, it is something simple. I'm going to manage. How do you manage compartment syndrome? So usually, the moment we suspect compartment syndrome, please, it's an emergency most of the times. We rush the patient to theater. Just rush the patient to theater. Okay, just rush the patient to theater for what we call what a fasciotomy. I told you that in compartment syndrome, the fascia surrounds where your compartment, they don't expand to accommodate the pressure. So to help with the situation, let's expand the fascia now to relieve the pressure in the compartment. So they do what we call a fasciotomy. So a surgical procedure to relieve pressure within the muscle compartment by cutting the fascia so that we can now have what? An elasticity, and then now we can now relieve the pressure in the compartment. So they do what we call the fasciotomy. Most of the time, they rush the patient to the table because if you don't do it as soon as possible, the patient will lose the limb out of ischemia. Okay, so we do it as soon as possible. We suspect it. Okay, to relieve what? To relieve the pressure. So we do what we call the fasciotomy. So this is what we do. They will bisect your hand, as you can see on the images. Okay, they will just bisect the fascia to relieve the pressure, so that the patient will now have proper blood flow and then proper nerve function. Now, this fasciotomy, after it is being done and the patient comes to the ward, most of the time we don't do any tight bandaging because already patient was having pressure in the compartment. Then we went to what? Relieve the pressure. So why do you want to apply dressing to further cause some pressures in the area? It is not going to be helpful. So most of the times, in some school of thought, they say we should leave the place ajar. We should just leave it without even covering. But then it stands a higher chance of getting what? Infection. So we can just use a loose dressing, okay, just to cover, not even to plaster, okay, just to cover the area to prevent what? Infections, okay, to prevent infection, because when you begin to leave the place too ajar, it can breed infection, okay. We are in a hospital, all kinds of germs, bacteria can just enter the wound and can cause a severe infection. And we all know that infection too is dangerous. If it enters the bloodstream, it can cause septicemia. So what they usually advise is that place some loose dressing on the area. It shouldn't be too tight, okay? Just a loose dressing to cover the area while the patient is on the ward to prevent infection. So they do what we call a fasciotomy, okay, as the initial surgical management, the initial management for compartment syndrome. Okay, then we can do other management like the RICE therapy. Okay, the RICE therapy. What does the RICE stands for? Rest, ice, compartment, and elevation. Okay, right or rest. Okay, rest, ice, compression. Sorry, and then elevation. So conservative management to reduce pain, swelling, and inflammation. We all know that there's swelling, and when once you apply ice will constrict the blood vessel and reduce what? The pain. And we can rest the limb as well, okay, and do the elevation. The elevation in compartment syndrome, there's a way we do it, okay. Please take note. When a patient comes to your ward with fracture and you suspect compartment syndrome, never elevate the limb above the heart level. No. Neither do you elevate the limb below do you bring the limb below the heart level? It is not done. It is not done. This is the reason why. See, a patient comes to your ward with, let's say, fracture of the tibia. There is swelling in the area. There's compartment pressure going on. You suspect compartment syndrome. Why do you think you should elevate the limb above the heart? Okay, to ensure venous return. Okay, so let's elevate the limb above the heart level. Well, perfect. You get venous return, so there will be blood will return back to the heart. But have you thought of getting blood back to the limb? Have you thought of that? You should also think of getting blood back to the limb, because once you elevate the limb above the heart level, getting blood to the limb becomes difficult. And then that is what we even want. We even want blood to get to the limb because there's ischemia, there's compartment syndrome, there's pressure. So why should you do that? So we don't elevate the limb above the heart level. All right. Now, when it comes to, bringing it below the heart level, it is wrong. Because if you bring it below the heart level, perfect. There's going to be adequate blood flow to the heart, to the ischemia area. But don't forget, there will be improper blood flow or venous return to the heart. So, in compartment syndrome, how do we elevate? Or not even say elevation. How do you position the patient? Please, always position the limb at the heart level. Okay, at the heart level. Okay, at the heart level. Always position the patient, the limb at, so that once it is at the heart level, we can get adequate or can get some blood supply to the heart and can get some from the heart to the limb. Because if the limb goes above the heart level, you will get the blood to the heart, but will not get the blood from the heart to the limb. And that is what we even want. Okay. So in compartment syndrome, we place the limb at the heart level. At the heart level. We can get some to the heart, we can get some from the heart to the limb to perfuse the area. All right. Someone is asking the question, please, if DVT is a risk factor for this condition, patients on test stocking, it's not also is it not predisposing the patient to go? Yes. In fact, DVT itself is a risk factor. There's a clot, there's improper blood flow, and there's pressure around the area that is pulling. Why do you have to even wear stockings? Okay, why do you want to wear stockings? Unless maybe the condition has not gotten to the compartment level stage. Because in DVT, we use test stockings to help with blood flow. I get in the picture. Yes, we use test stockings to help with the blood flow. So if we suspect DVT to prevent compartment syndrome, let's use it so we can get adequate blood flow. But once compartment syndrome sets in, as a result of DVT, please take off the compartment, the test stocking, because it will cause pressure on the area. Okay, it will cause pressure on the area. So that is it. Something you should know regarding the DVT. Okay, all right, good. Okay, all right. Then two, pain management, medications to manage pain. All right. So someone may ask, why is it that in compartment syndrome the patient does not respond to pain, but are still giving pain medication? The answer is that, see, the way they suffer is severe. The way they become agitated sometimes because of the pain, and then they begin to become very anxious. And sometimes we give the pain medication not to correct the pain, to make them comfortable. At least if we give morphine, it can give them some comfort, okay? Not to actually correct the pain, because the pain can only be corrected when you get adequate blood supply to correct the ischemic pain, okay? So the reason why we give them pain medication is simple, just to correct what? Just to correct, and then, just to give them comfort and then calm them down, okay? And to calm them down. Then three, we have physical therapy. So rehabilitation to restore strength, range of motion, and function. Of course, patients have issues with their limb, there's fasciotomy, the patient is trying to heal. So we can do some physical therapy like physio to help restore strength, range of motion, and then function. Four, monitor neurovascular assessment. Of course, patient comes with compartment syndrome. There's reduced blood flow in the compartment, preventing blood flow to the area or to your compartment. What should you do? What should you do? What you should do is that you should monitor the patient pulses. Can I feel the patient pulse around the limb? Can I feel? If you don't feel with your hand, please, on your NCLEX exam, when you check a patient pulse and you don't feel with your hand, go ahead and use a Doppler. Please, RNs, whilst you are practicing, if you check a patient pulse with your hand and you don't feel it, don't conclude yet that there's no pulse. Go ahead, you can use a Doppler. A Doppler can help. Once you use a Doppler and you can't see the pulse, then you can now conclude. Okay, all right. So once you feel with your hands, you don't see the pulse, use a Doppler. A Doppler can also detect. If the Doppler cannot detect, then you can, Charlie, where the thing is getting to the patient is getting compartments because we can't see the pulse. We don't feel the pulse. Something must be done as soon as possible. Check the temperature around the limb. Is it warm? Is the limb warm? Is it cold? Is it cold? Is the color red, or is the color bluish? Is the color pale? Please, all these things are assessments you must do to diagnose or to help you manage a patient with compartment syndrome. 5, remove any tight clothing if there's any. Okay, remove any tight clothing if there's any. And lastly, monitor patient pulse. I think I said already. Monitor patient pulses. Okay. So what are some complications of compartment syndrome? What are some complications of compartment syndrome? One, nerve damage. I told you, permanent nerve damage can occur if compartment syndrome is not treated properly, because if the pressure keeps on building up in the compartment, and the compartment is made up of your muscles, blood supply, and nerves. So if the pressure builds up on these nerves, it can cause permanent nerve damage. Okay, that is when the paralysis starts setting in. Okay. Two, muscle necrosis. Muscle death, okay, can occur due to prolonged lack of blood flow. I've explained this already. Three, infections. Infection can occur if fasciotomy site is not properly cared for. I told you this, that after the fasciotomy, because sometimes they tell us to leave the place open without any dressing, it can lead to infection, but you can just use some loose covering, okay, on the side to reduce infection. Then lastly, amputation. If the condition has gotten to the stage whereby there's nothing that can be done about the issue, they just have to amputate. So please, it is very, very severe. I'm sure most of us here have seen a condition like this on our unit because of our sorry to use this word, but our mere negligence, okay, on the ward. Patient lose the limb because the patient came with fracture, and the patient was on the ward still complaining of pain. You give them morphine, patient was still complaining of pain, and I was like, oh, this patient cry, you like complaining to do, please allow us to work. But in the next moment, you go and the patient has lost the limb because of compartment syndrome. Simply because we didn't know that in compartment syndrome, the patient does not respond to analgesics. Okay, so please let's take note. Let's save patient on our unit. The little mistake that we do by not realizing the temperatures, the changes on the limb, we are going to do what? We are going to cause a patient to lose the limb. Okay, so these are the complications of compartment syndrome. Right, we are moving on to CAS care. Any question on compartment syndrome before we move to CAS care? Any question? Okay. All right. Okay. All right. So,
Sir,
those, Madam Hamdia, yes.
if somebody is having compartment syndrome due to
Uh,
maybe the cast to be too tight, like
uh,
cutting off or removing the cast, wouldn't it be enough for the compartment syndrome to resolve, or we need to do
yes.
that?
Yes. It's done. It's part of the management. Okay. Okay. Maybe I was going to add it to the cast care. Okay, because they are related. You can even see on my screen. Okay. You can even see on my screen. Have you seen the woman in the what do you call it? There is the move or whatever color. Okay. Have you seen the curtain? We call it bivalving. Okay, the actual word we should read is we call it bivalving. If the cast is too tight, compressing on what? Compressing on the tissues, okay? We call it what? Bivalving. You can just pick a scissor and then cut it to relieve the pressure, and it can restore perfusion, okay? It can restore perfusion, okay? It can restore perfusion, okay? All right. Someone is asking, does incision? Okay, yes, because incision and drainage, we are removing fluid. Okay, we are removing fluid. But you see, let me say this: when the issue has gotten to a stage, whereby you can really see that there's a severe tissue death. See, that one you must do fasciotomy. Okay, you must do fasciotomy. But in the initial stages, when the patient comes and then you say, hey, okay, I'm beginning to see swelling. Well, but patient can move the limbs. Patient limb is still warm. Okay, patient limb is still warm. Patient still have pulses, meaning it has not gotten to compartment syndrome yet. That one we can do incision and drainage. Let's take up the fluid to relieve the pressure, and we can now have a normal free flow of blood. Okay, but when it gets to the stage whereby pulses are not being felt, color has to change on the limb. Please, let's do fasciotomy. So that one can use, okay. And Mr. Ezekiel, yes, you can use the same unit, okay. All right, then Mr. Emmanuel, you are adding up. He said adhesion is also a complication of compartment syndrome. So thank you for the addition. Okay. All right. So let's move on to cast care. Cast care. Okay. Cast care. All right. So what is a cast? A cast is a medical device used to support and protect a broken or injured bone, okay, or soft tissue. So it is typically made of plaster or fiberglass. and it's applied to the affected area. Okay, it is applied to the affected area. So we all know, as you can see on this image, you see they are usually made of plaster of Paris, something like a chemical. Okay, and they are very, very, very water soluble. So before they apply a cast, they dip the substance into water and then apply. Eventually, because of the chemical reacting with the water, it becomes hard, and then they dry and become very, very hard. Okay, right. And then the main reason why usually they apply cast is that it is used to support and protect a broken bone. Because if someone comes a fracture and you don't help, okay, with the reduction, because they use POP and then other management like traction to help with the reduction and that stuff, okay, and you don't do this POP, it will keep on immobilizing the limb. But with that, the patient will get consistent injury because the POP has not been applied to keep the limb at one side. Since it has not been applied to keep the limb at one side, what is going to happen? Patient limb keeps on moving here and there, and they can get what? They can get consistent injury or consistent pain. So to prevent that, to protect the bone, and then to keep the bone well immobilized, okay, we apply a cast on the limb, okay? We apply a cast on the limb. So it is typically made of plaster and fiberglass, and it's applied to affected area to do what? One, immobilize, hold the bone and joint in place to promote healing. Two, protect. It shields the affected area from further injury or stress. And then lastly, support. Provide stability and support to the affected area. Okay, and that is the basic functions of what? Of cast or POP. Okay, now after you apply POP, what are some of the assessments you must do to ensure that, okay, you've now done a good job, the POP is well placed or well applied? One, neurovascular assessment. Please, right after applying POP, okay, after checking the POP getting dried, please start checking the color and temperature. Has the color started changing to blue? Is it becoming black? Is it normal color? Is it red? Is the limb warm? Is the limb cold? This will help you assess and see whether the cast is becoming tight or the cast is too tight, impeding blood flow to the extremity. Okay, so the assessment you do after you apply a cast is to check the color, temperature. Two, skin integrity. Is there any wounds going on in the patient's skin? Do we have a normal skin integrity? Do we have some smelling odors coming out from the POP? Okay, all these things are some of the things you do to check for skin integrity. Then positioning. How do you position someone who has gotten a cast applied? Okay, the position of the patient you must assess very, very, very well. We'll talk about them very soon. Okay, psychological reaction. Psychological reaction. Is the patient, accommodating or, adjusting to the POP? Because, when I was coming from my house, I didn't have any POP. So why am I having this? Sometimes, many people, the little thing that applies to their health, they get emotional, okay? To check their psychological reaction towards the POP application and psych them out as such. The last point on the assessment we can do, the gastrointestinal, okay? Gastrointestinal alongside cardiovascular issues due to immobility. Now, what cardiovascular issues can occur due to immobility? We all know that for a blood to flow properly in the blood vessels, there must be mobility. Patient must walk for blood to flow. You get venous return and the rest. So prolonged immobility causes what? Venous stasis. We all know this from DVT, that is the virtuous triad and the rest. Okay. From prolonged immobility, we get what? Venous stasis. The blood begins to pull up and begins to form clots. When the blood begins to form clots and they are dislodged in the circulation, it can attack the heart, okay? How the heart to function, okay? All right. And imagine a situation whereby there's clot formation in the blood vessel. When the heart pumps the blood, it meets a resistance. What do you think the blood will do? The heart will do, sorry. The heart will be like, hey, see, I'm pumping the blood, but I'm meeting a resistance. There's a clot. Because the patient has not been mobile. They don't walk for some time. They are still idle. So this has caused the blood to become pull up, and it's causing clot. I push the blood, it's not going. Can I do something? So the heart will compensate by increasing the pressure at which it pumps the blood. This will eventually cause hypertension, put too much stress on the heart. Okay. Then lastly, GI effect. when you are immobile for a longer period of time, we all know that consistent movement increases peristalsis, or it helps with peristalsis. So if you are immobile consistently, it can cause constipation. Okay, it can cause constipation. All right. Good. Now, cast care. What are some of the care we should give to patients after POP? These are the last things we are doing, and then we bring our meeting to a close. Okay. All right. One, swelling. If the patient has swelling after a cast has been applied, what do? One, you elevate the limb on pillows and then consistently wiggle the toes to reduce swelling. When I say wiggle means move the toes. If it is your hand, move your fingers. If it is your lower limb, that is your legs, move the toes in the POP. Consistently doing this with the limb well elevated on the pillow above the heart level, it can cause proper venous return and reduce the swelling. So if a patient comes to your ward after POP and you see swelling, just put the limb on a POP above heart level to ensure venous return and reduce the swelling. Patients sometimes complain of itching because, trust me, the POP can really itch. Okay, what should you do? One, you can use air dryer or place the patient in a cool environment or cool setting. You know, these days our ladies are here, they can help us. They usually have these fans that they use when they are getting married and the rest. Okay, the dryer, you can buy some for the patient. Okay, the patient can buy some, and then they can be using them around the POP, or you can get a fan close to the patient, or you can get these little fans around. Okay, and then be fanning the patient. It keeps the area cool and reduce the itchiness. Okay, it keeps the area cool and reduce the itchiness. Okay, then how can you also control the itching? Please, by gentle tapping. You just tap the area around the POP, okay, by gentle tapping. It can reduce or relieve the itchiness, okay. So gentle tap on the POP to relieve the itchiness, okay. Please do not insert anything in an attempt to, correct the itchiness. Never insert anything to correct the itchiness. Please take note. It is either you are gentle tapping on the POP or you are using an air dryer. All right, in severe instances whereby the air dryer is not helping, the gentle tapping is not helping, what do? You can give an antihistamine, okay? Hydrocort, cetirizine can be given to the patient to reduce the itchiness, okay? All right. Skin integrity. Under skin integrity, how do you care? Under skin integrity, one, report any foul smelling from POP because this could mean infection, okay? Any foul smell you see from a POP, any foul smell you sense from a POP could mean infection, okay? It could mean infection. Therefore, you must do what? You must ensure that there is no foul smell, okay? And you must report as such, okay? You must report as such. Do not wet the POP. Always make sure the POP is dry. In fact, I told you that the substance they use to apply the POP or the bandage contains some chemicals. They are water soluble. If water gets to the POP, they make them soft and affect the integrity of the POP. It will not help maintain that immobility that you want to maintain. And even when the POP gets wet and it gets to the patient's wound or the fracture site, it will cause infection. So never wet the POP. 3, always assess the skin to note any skin breakdown. Okay, always assess the skin to note any skin breakdown. Assess the skin. Is there any cracks on the patient's skin? Is the patient having a normal skin integrity? Okay, always you have to assess. Is there any foul smelling? Okay, is there any wound in the POP? Okay, then you can do what? You can manage as such. Then lastly, ensure there are no cracks on the POP because if there are cracks on the POP, water can enter. Okay, water can enter, and even cracks on the POP will not help us get a proper integrity to maintain the immobility and support the fractured limb. All right. Then lastly, circulation. Lastly, circulation. How do you care for a patient with POP? So after POP, one, check temperature of toes in cast all the time. In fact, every time you go to your ward on every shift, please make sure that you check the temperature. Is it cold? Is it black? Is it warm? Check the temperature. That is when you begin to detect any abnormality. Make sure the color of the toe is red and not blue or black. Anytime your color of the extremity changes to blue or black, it means that there is improper circulation to the area. There is improper circulation to the area. Okay. 3, ensure normal capillary refill time. Okay. Ensure normal capillary refill time. Okay. Ensure normal capillary refill time. It should be less than 3 seconds. Okay. Less than 3 seconds. This indicates what? Proper circulation. All right. Next point. Report any bluish discoloration. I think I said this. When the POP becomes too tight, and it compresses on the compartment, it compresses on the tissues, and it doesn't allow proper blood flow through the area, what is going to happen is that the color begins to change because there's improper blood flow. Okay. So you can do the bivalving here. You can just cut the POP. You need the pressure. Okay. All right. So POP shouldn't be too tight. As I said, POP shouldn't be too tight. If POP becomes too tight, they compress on nerves, and eventually it will not allow proper blood flow. Okay, it will not allow proper blood flow. Then report any numbness and tingling. As I told you, once you see numbness and tingling, please start suspecting of compartment syndrome, because once you see numbness and tingling, it means that the pressure is increasing. I am preventing proper blood flow through the compartment, causing what? Numbness and tingling sensation. Then lastly, report any severe pain that can't be managed. Another sign of compartment syndrome. Okay? Report any severe pain that can't be managed. Once you see this, a 55-year-old man was admitted to your ward with fracture. A POP was applied. After 1 hour, you give patient complaints of pain. You give morphine. Patient tells you, I'm still having pain. You give another morphine. Patient still complain of pain. Please, this is a sign of compartment syndrome. Okay, compartment syndrome. A patient was admitted to your unit with fracture. POP was applied. After 30 minutes, you went to check the temperature around the patient lip. It is getting cold. Please quickly bivalve the POP. Just cut the POP, because if you don't, eventually pressure will increase and it can cause compartment syndrome. So compartment syndrome is simply a condition whereby your compartment, made up of your muscles, blood vessels, and nerves, becomes what? Increasingly experiencing pressure. Okay, or when it begins to experience pressure to the point that the pressure is not allowing enough blood flow through the compartment, causing nerve damage and ischemia. Okay, you begin to have pulselessness, hypokalemia, pressure, pain, and that's when it's important to analgesis. You can do fasciotomy, check the patient pulses, and it can correct compartment syndrome. Cast is applied to maintain what? Immobility, or sorry, to help to cause immobility of the limb, of a fractured limb, to help maintain it in the right position to prevent further injury and stress. Okay, once you apply a cast, check for circulations all the time, check the skin integrity, check and see if the POP is wet. Okay, please check for itchiness. When the patient complains of itchiness, just gentle tap on the POP, apply some cool air, and the patient will be relieved. So this brings us to the end of our compartment and cast test. I have some questions on my slide. I want us to test our knowledge on it. But before that, I want to find out if anyone have a question to ask on compartment syndrome or cast test. Anyone with a question? Yes.
Osaki,
Yes.
please, the fiber glass.
Yeah.
I know that one dries faster than the plaster, right?
Yes.
Please,
Yes.
do you remember can you tell us the hours, or it's not important? Like,
Oh, not really important. Okay.
okay,
Maybe,
okay.
well, I find how many hours it takes for fiberglass.
Yeah, I know
Like,
fiberglass dries faster than the POP.
oh. Okay. Usually within
Mm-hmm.
32 hours to 24 hours, it will dry up. Okay. It can, but sometimes the moment the patient POP is applied for the fiberglass, after 3 hours, 4 hours, 5 hours, you can see the signs. Okay. By 24 hours, it has become totally dried. Okay.
Okay,
Become
all
totally
right.
dried. Yes.
Thank you.
Welcome. Any question? Okay.
Yeah, hello, Bosaki.
Yes.
Please, I just want just maybe this clarification. Okay, let's talk about the fasciotomy. With that one, does it actually pertain to, or only pertain to those with the internal factors Because I don't know for the casts and then the POP such, I don't know if you
Mhm.
have to also do fasciotomy for that one.
Okay,
And
all
then
right.
the piece or the skin,
Mhm.
is it actually when you assess it, do you feel it's becoming warm or cold? Because that side at times it's not that, it's
Okay, all
confusing
right.
me these
I'll
days.
talk about it. Okay. So
Mhm.
your question, first of all, see, fasciotomy can be done. You see, the internal and external factors, they are just risk factors. Okay, they are just risk factors that causes compartment syndrome. But see, if a patient gets POP applied on the skin and you want to correct compartment or you want to prevent compartment syndrome, don't wait for the ischemia to set in. Once you begin to see that the patient is not having the normal temperature, see, just do the bivalving, cut the POP. If it is tight clothing, remove the POP. Remove the tight clothing. If it is dressing, please loosen the dressing so that we don't go into a stage whereby the patient limb is not working at all, because compartment syndrome starts setting after 6 hours. Okay, most at times after 6 hours when you apply the POP, and or let me say there's something causing compartment syndrome, and you don't eliminate it after 6 hours, the thing will start setting in. So please try and correct whatever is causing it within some few hours after suspecting any change, so that it doesn't lead to compartment syndrome. But if it gets to compartment syndrome, whether by POP, what we do is that let's take up the POP, but still the patient feels pressure in the limb because the POP has compressed on the compartment for long to the point that there is pressure. For that, the only thing we can do is the fasciotomy to still relieve the pressure in the compartment. Okay. All right. Regarding the okay.
Okay.
Regarding the time, whether the warmth or the cold, one thing that you should know is that, see, initially, in the initial phases, patient will be warm because at that time, you've not gotten a severe blood flow impeding. Okay, the blood flow getting impeded has not gotten to the extreme yet. So in the initial phases, you may feel the limb to be warm. But when there is severe obstruction due to increasing pressure, because the pressure starts somewhere. So once it begins to start, you may feel the warmth. Once it gets to a stage whereby the pressure has severely increased, please, at that point, you will not get or you will not feel the pressure. You will not feel the warmth because there's ischemia. Coldness are setting now. This will cause what? This will cause the pressure to what? And the temperature to get cold. Okay, that's why we say that there's pyroclothermia. Okay, all right, good.
Thank you very much, sir.
You're welcome. Okay, someone is asking Mr. Richard, what is the optimal times you release pressure to achieve sustainable outcome? I told you within 6 hours, okay? Because if you don't want to manage the patient on time, within 6 hours, compartment syndrome will set in, okay? All right. Madam Sefa, okay, Madam Mr. Imano say fiberglass 30 minutes, okay. So for the fiberglass, within some few minutes to hours, it is getting dry, okay. All right. It looks like most of the cast you are talking about is mainly the lower limbs. I think assessing for GI, the patient with upper limb cast does not necessarily matter. Or of course, it does not exactly. You are right, of course, okay. Of course, if someone have POP on the hand, they can move. So obviously, there's going to be what increased peristalsis. There's no need for constipations and the rest. Okay. All right. Good. Please, any further question? Any further question? Any further question? All right. All right. So I think we are good to go. So let's solve some questions. Okay. Let's solve some questions. But please do know something. Before we do the questions, kindly give me 5 minutes of your time. Okay. 5 minutes of time. Okay. To tell you who Excellent RN. Okay. Who we are. So Excellent Iron, once again, is an NCLEX tuition firm, okay? Yes. We've been helping nurses to pass the NCLEX exam, okay, for about 3 years, okay? For about 3 years. Myself, Amingo. I'm sure most of us knows Amingo and Sister Mimi. We've been helping nurses to pass the NCLEX exam on their first attempt. In fact, there's no step in the process we cannot help you with. From credential evaluation, whether that's through merit, JSA, WES, whatever. ATT application, Board of Nursing registration, NCLEX tuitions, we do everything, okay? NCLEX test booking, even hotel booking. We can book hotel for you, assist you with transport system in Kenya, and South Africa. Also, when it comes to IELTS tuition and then other things that, I mean, we can assist you with regarding this process, we can help you with it. Okay, so if you know anyone preparing for the NCLEX exam, please, you can refer them to us. In fact, our referral program is still on. If you refer someone to us, you will win 150 cedis instantly, okay? You win 150 cedis instantly, okay? And then even from today's lecture, I'm sure you are convinced to what? To refer your siblings, your brothers, your colleagues to Excellent RN. Trust me, at Excellent RN, we say quality content to pass NCLEX, okay? Our tuition, how much for IELTS tuition, please, and for how long, okay? All right, for the, I'll talk about that later, okay? Let's finish the question, I'll talk about that, okay? All right, so please, you can reach out to us, and then regarding NCLEX, if anybody's having any issue anywhere, they are applying, Texas board is not working, whatever, you can assist the individual, okay, through the NCLEX process, okay? You can assist the individual through the NCLEX process from start to end without any problem, okay? Without any problem, okay? Without any problem. All right, good. So that is something small about Excellent RN. You can visit our website, okay? www.excellentrn.com and read more about us, okay? And read more about us. Anyway, that's that.
Hello.
Let's, yes. Is anyone talking?
But what you are talking about, is it the assistance that you are giving? Is it free
I'm asking
or
about the tuition fee.
Okay. So you, because these questions are coming, do you know something? Let's finish the questions, okay? Then I'll talk about these things, okay? Let's finish the question. I'll talk about these things so that we can have time and discuss some few things, okay? All right. Good.
Okay.
All right. Good. All right. Good. So let's solve the questions. Question 1. The nurse is caring for a client with fractured fibula. Okay. The nurse is caring for a client with fractured fibula. Which assessment prompts immediate action? Which assessment prompts immediate action by the nurse? A. Reported pain of 4 on a scale of 0 to 10. B. Numbness and tingling extremity. C. Swollen extremity where the injury occurred. D. Report of being cold in bed. Which of these will prompt immediate reaction by the nurse? Numbness and tingling, swelling extremity, where the swelling occurs. Okay, I see B.
The B.
B, okay.
Yes, sir.
Sign of what? Improper blood flow, paresthesia, nausea, what do you call it? Numbness and tingling, right? So the answer is B, okay? All right, so the client with numbness and tingling of extremity may be displaying the first signs of what? Of acute compartment syndrome, okay? Acute compartment syndrome. This is an acute problem that requires immediate intervention because of possible decreased circulation. Moderate pain and swelling is an expected assessment after a fracture. These findings can be treated because if you are scoring 4 on the pain scale, it's fine. But if the pain is like 10 and then you give morphine, it's not work, please, it's compartment syndrome. Don't get confused, okay, on the NCLEX. All right. These findings can be treated with comfort measures. Being cold can be treated with additional blankets or by increasing temperature in the room. All right, so the answer is B, numbness and tingling. Let's move on to the next question. All right, a patient with comminuted fracture of the tibia and fibula is treated with open reduction and application of an external physator. The next day, the patient complains of severe pain in the leg, which is unrelieved by ordered analgesics. The patient toes are pink, but the patient complains of numbness and tingling. The most appropriate action by the nurse is to A, notify the healthcare provider. B, check the patient blood pressure. C, assess the external physator pins for redness or drainage. D, elevate the limb and apply ice over the wound site. Yes. Okay. Okay. All right. Why? Because there's an external physator. You know, external physators are placed by what? By the healthcare providers. It is surgeons that does it, okay? So you should do what? You should notify the healthcare provider. You are being what? Meaning working and understanding perfectly. So notify the healthcare provider, okay, as your answer. So the client or the patient manifestation, okay, the patient manifestation point to compartment syndrome and delaying diagnosis and treatment will lead to a severe functional impairment. there is no reason to suspect the patient's symptoms are caused by hypotension or hypertension or by infection at the pain side. Elevation or ice application to the leg will decrease arterial flow and further reduce perfusion. Okay, further reduce perfusion. So let me tell you something. You know, on my slide, there was a slide I point out ice, rice. Please take note. The ice application, it is not when you see signs of compartment syndrome, because the question you see on my screen, the patient was having pain, not relieved by analgesics, meaning the patient is having compartment syndrome. You can only use the ice when patient comes with fracture, and then there can be swelling in the future. So that one, let's apply the ice to prevent the swelling from setting in to even lead to the compartment syndrome, because once the compartment syndrome sets in, you can't apply the ice. You need blood flow now. So why do you apply ice in compartment syndrome? It will prevent blood flow, right? So please get the difference. You apply the ice when the compartment syndrome has not yet set in, because once it sets in, we need blood flow. Once you apply ice, constriction will set in to not allow blood flow to the place. All right, so let's get the difference. Next question. A client has an arm cast and report that it feels really tight and fingers are puffy, meaning that the blood is not flowing. What is the nurse's best response? A, elevate arm on 2 pillows and apply ice to the cast. B, continue to take your ibuprofen NSAID until the swelling subsides. C, it is normal for the new cast to feel a little tight for the first few days. Is it true? Okay. D, please come to the clinic today to have your arm checked by the healthcare provider. Yes. Okay. D. All right. Okay. All right. Okay. So assessment must be done. Okay. So puffy fingers and feeling of tightness from the cast may indicate what? May indicate the development of compartment syndrome. The client should come to the clinic that day to be evaluated by the provider, because delay in treatment can cause permanent damage to the extremity. Okay. Ice and morphine are acceptable actions, but checking the cast is a priority because it ensures cast patient safety. Don't forget, in nursing care plan, what comes first? Assessment. So before you apply the ice, even though they can be correct actions, let's first do assessment. So in nursing care plan, assessment is first. On your NCLEX, anytime you see questions and in the options, there are assessment questions or assessment options. Most of the time, that is the right answer. Okay. So assessment is the first thing you do in nursing care plan. So most of the times, assessment are the right answers in your NCLEX questions. All right, good. Next question. A patient has developed a compartment syndrome following an application of a cast to a fractured tibia. Which of the following responses is the most accurate for prompt action in treating compartment syndrome? Which of these is the most accurate for prompt action? A, decrease the level of the pain. B, prevent tissue death, which can occur within 2 to 4 hours. C, prevent further complications. D, decrease swelling in the extremity. Which of these is the most accurate for prompt action to help with the patient?
B.
Okay. B, right?
Yes, sir.
B, because I mean, the little thing you do, you can lose the limb. Okay, so prevent tissue death, which can occur in 2 to 4 hours. Okay, all right. So this brings us to the whole review of compartment syndrome and then cast care. All right. Have you learned something today?
Yes, sir.
Okay.
Yes, sir.
All right. So I'm sure you will apply on your wards and then on your NCLEX exam. So okay. All right. So let's come back to our conversation. Okay. All right. So regarding this, many people were asking. Okay. So once again, you can do a referral to us. Our tuition primarily is for 4 months. Okay. Our tuition primarily is for 4 months. Okay. Our tuition primarily is for 4 months. And then the 4-month package, we charge 1,850 for the 4 months. Okay. We charge 1,850 for the 4 months. Regarding the payment, you can speak to us and know how we structure the payment. Though usually we take all upfront, but you can just speak to us. You can know how to go about the payment. Okay. You can know how to go about the payment. Right. You can reach out to us regarding that. Now, regarding these steps, the credential evaluation Board of Nursing registration, the ATT application, book test booking. We can do all these things for you. We can assist you with all this. Yes, Ghana cedis. So it is 1,850 Ghana cedis, not dollars. 850 Ghana for 4 months. Okay, for 4 months. After your package expires after 4 months, and you feel that you still need an additional training, you can renew your package, but this one at a lesser cost. Okay, at a lesser cost. Okay, at a lesser cost, right? At a lesser cost. Okay.